In the surgical profession, there's a curious gap between what people say at courses like this and what they actually do in practice. And I think that's very dangerous. This again is from Codman's cartoon, where the patient has no idea what's going on. One side is the clinical people, or the people concentrating on getting as many of the golden eggs that this ostrich goose is laying. And the clinical truth is nowhere near the patient or the surgeons or the other practitioners doing it. One thing that we've kind of worked hard, and it took 6 years of pilot data to actually get some funding, and it was a lot of work to convince Rick Deo to kind of head this up, but we finally last year got some funding from the NIH to set up a multidisciplinary clinical research center. It's headed up by medicine because only people with intense research skills can be trusted with millions of dollars that the NIH is going to give to this center. The 4 projects we're doing, and the 3 of them are spine. The key one for spine is this cohort study of discogenic pain. Basically, we don't know what the diagnosis is, we don't know what the proper predictors are, and we don't know what the outcomes are. So we plan to follow a large cohort over 2 to 3 years and see which variables predict what. And we feel this is a precedence necessary for randomized trial. Because we tried doing a randomized trial 3 years ago, we approached 30 patients, not one accepted randomization. We couldn't get a single patient. They either decided surgery was way too invasive, they didn't want anything to do with it, or they said, I want to have surgery, why should I wait longer if I want to do it? So we couldn't get anybody to accept randomization.
Our next speaker is Julie York, and Julie's going to speak about for lower back pain, what tests do we really need to perform?
Jens asked me to review what tests are needed and what the diagnostic workup should be for low back pain. It's very important to understand the psychologic factors and their relationship to low back pain before you start getting too deep into any of the diagnostic studies. You might end up finding an abnormality in someone you don't want to treat. As Sohail alluded to, there are many causes of low back pain. Low back pain secondary to instability, tumor, infection. That's easy to diagnose, and that's not the topic for today. I tend to categorize degenerative disease causing low back pain into spondylosis, discogenic pain, and facet syndrome. Patients with spondylosis typically have disc space narrowing, end plate sclerosis. They have osteophyte formation. MRI demonstrates decreased water content in the disc space and bone marrow signal changes. In a patient with an abnormal disc, subacute repetitive stresses on that disc can lead to abnormal movement and may be the cause of pain. This concept of segmental instability doesn't identify an exact cause of the pain. It's probably related to discogenic pain, but it differs from that diagnosis. Discogenic pain or internal disc disruption is diagnosed in patients who have generally fairly normal-looking plain x-rays. You don't see a lot in the way of degenerative changes, but on MRI you see decreased signal in the disc space here at 5'1". And this is generally diagnosed with concordant pain seen on discography. And finally, patients with facet syndrome, they generally have pain that's worse in extension or rotation. The concept of facet degeneration as a cause of back pain was first introduced in the 1930s, and it's a controversial theory even today, but MRI generally demonstrates abnormalities in the facets, degenerative changes, and many authors feel that this diagnosis can be made with facet blocks. Well, looking at the diagnostic studies that are available, your plain radiograph, CT scan, there's not much controversy there. Plain x-rays are useful in assessing alignment. Dynamic studies for instability. CAT scan can show structural abnormalities that may account for the pain. But I'm going to concentrate on MRI, discography, and facet injections. Well, MRI clearly demonstrates herniated discs, but herniated discs cause radicular pain. They're not the basis for low back pain. For the diagnosis of back pain, some studies have suggested that the signal intensity of the discs, the disc space narrowing, and bone marrow intensity changes may be significant. In a study by Ito et al., published in Spine, he analyzed the relationship between abnormalities seen on MRI and positive discography. There are 101 discs in 39 patients that were evaluated with MRI and discography. And the results are summarized here, showing the prevalence of the feature seen on MRI, the likelihood ratio for the diagnosis of internal disc disruption, and the resulting diagnostic confidence. This is as a percent. I need to say that all these numbers are based on a pre-test prevalence of 40%, which comes from other studies and basically means that for a given population with chronic, unremitting low back pain, the prevalence of internal disc disruption is 40%. So a physician in seeing any given patient with those symptoms can be 40% certain before doing any tests that the patient has internal disc disruption. And then this right-hand column shows how much more confident they can be if any of these findings are found. The other study on MRI that I just wanted to mention is Scott Bowden's study looking at abnormal MRI findings in asymptomatic patients. He evaluated 67 asymptomatic patients, evaluated their MRIs, and found abnormal findings in about 30%. There were herniated discs in 24%, lumbar stenosis in 4%, and disc degeneration in anywhere from 34% in the youngest patients to 93% in the patients aged 60 to 80. So this study and the previous study both demonstrate that there's a high incidence of nonspecific findings on MRI.
I'm going to talk about the ideal indication for fusion, the ideal indication for treating a degenerative lumbar condition without fusion, and then just show some cases, because this is something that's so controversial and involved that within a 5 to 10 minute time frame, there's not really a consensus that we're going to be able to come up with. So as you're all aware of, the indications for fusion remain controversial, and people spend an inordinate amount of time and energy justifiably at national meetings arguing this point. In non-degenerative processes, the need for fusion is frequently obvious. I don't think anyone would argue or write to the New Yorker magazine that this patient was unjustly treated operatively if they presented after being run over by a semi-truck, as they were, after falling off their motorcycle and having undergone this extensive stabilization procedure. Or in this osteomyelitis case, where a patient really has essentially lost the lower part of their lumbar spine and required a fairly extensive and involved reconstruction. What I'm going to address primarily is the surgical treatment of degenerative lumbar conditions, or when to fuse in degenerative conditions, i.e. decompression alone or decompression and fusion. The ideal situation for decompression alone is one where a patient would have symptoms primarily of neurogenic claudication with actually minimal or minor contribution from back pain. And of course, that's also debatable. With central or lateral recessive stenosis would predominate over foraminal stenosis, meaning a less of a likelihood to have to actually destabilize the spine in doing your decompression. A patient which has low disc height and therefore some inherent stability already built into their spine. Broad coronally oriented facet joints, which again would minimize the likelihood of destabilizing the spine when performing an adequate decompression. No evidence of spondylolisthesis, and no instability on flexion extension radiographs. Here's an example of broad facet joints that would be amenable to that type of procedure, or that type of approach. Whereas the ideal situation for fusion, again, arguably to some extent, would be when back pain is a major component, or when foraminal stenosis is a key component, again, increasing the likelihood that an appropriate decompression would destabilize the spine. Someone whose disc height is relatively well preserved, someone who has narrow or more sagittally oriented facet joints or evidence of spondylolisthesis, clearly when they move on flexion extension radiographs, and again, arguably, if this is at a level adjacent to a fused level. So the actual indication is quite simple. If there either is pre-existing instability or instability will be created or anticipated after surgical procedure, then one should fuse. As we come back to Sohail's talk, which is when that surgeon quoted, "No one can really ever prove or disprove instability because we don't really understand what constitutes instability." Here I included this slide, just an example of a far lateral disc herniation at the L5S1 level, where one would be hard-pressed to address that pathology without destabilizing that facet joint. or without resecting an inordinate amount of that facet joint at the L5-S1 level. So again, instability is difficult to define. Radiographic criteria have been established according to Punjabi and White, 4 millimeters of translation, 10 degrees of rotation or higher at L5-S1 level. Very few patients actually present with those criteria. And there's, of course, the argument that the presence of traction spurs imply instability, or that modic changes on MRI, again, imply instability and therefore should be addressed with a stabilization procedure. I'm just going to show a couple of cases now. Essentially a patient who had a minimal grade 1 spondylolisthesis with multi-level stenosis who underwent an, I believe, L3 through S1 decompression posteriorly and then had worsening low back pain and worsening leg pain. And you can see that this patient actually had, and these are the supine CT scans on the upright, preoperative x-rays. It's actually a grade 2 spondylolisthesis that the patient has progressed to with pretty severe foraminal stenosis at the L5-S1 level. And this patient went on to necessitate the L5-S1 level being addressed with an interbody fusion as well as posterior fusion, and this was actually extended up to encompass the previously decompressed levels in order to minimize the likelihood of instability actually progressing at those levels. Again, an arguable point. Here we have a patient who, once again, following decompression, 2-level decompression at L3-4 and L4-5, had progression of severe right leg pain or development of severe right leg pain as well as low back pain. You can see this lateral listhesis on the AP radiograph with a scoliotic or coronal plane deformity as well. And you can see what happened in the patient's previous decompression is that the inferior facet of L3 was completely resected, which led to the progression of these symptoms and the deformity. So in a patient like that, I think one would be hard-pressed to do a revision decompression alone, and this patient underwent an L3-4 decompression, rather fragile patient, so we did a limited approach. I think one could argue that you could carry that caudally down to the previously decompressed level below as well. And here's another example of a case which some may consider controversial, which is a patient with a 2-level spondylolisthesis, a grade 1 to 2, I guess, right on the fringe at the L4-5 level, where I believe most of her symptoms were coming from, with a spondylolysis at that level, and a grade 1 spondylolisthesis with a spondylolysis at the L5-S1 level. And having decided to address, to decompress and stabilize the L4-5 level, whether to include this apparently radiographically stable segment, which I did in this 2-level interbody fusion with posterior fusion instrumentation. So anyways, those are just a few of the issues that we're faced with every day. And of course, when to fuse remains controversial, will continue to remain controversial because of the fact that we do not have a great way to define instability. And decisions have to be made on an individual basis, not on a carte blanche basis. And by that I mean, I sometimes hear that someone is a fuser or a non-fuser or doesn't believe in fusion or believes in fusion all the time. And I think that probably does a disservice to our patients. They fall into very broad categories, and I think that there are certain indications for both approaches. Thank you.